Assalamu alaikum. Today I want to cover with you some things that my your professor did not clarify about thalassemia. Okay, first, what's thalassemia? Just let's do basics step by step. So thalassemia is referred to like a group of blood disease characterized by decrease or absence or synthesis of one or more than one of normal globin chain, because our hemoglobin consists of alpha chain, beta chain, right, and hemoglobin, right. So if there is a deficiency of this alpha chain or beta chain mutation, deficiency or absence, this is what we call thalassemia. Thalassemia, it has two parts. First is the alpha type and and beta types. Alpha types, it's usually on chromosome 16 where there's a deletion, so it's absent, it's deleted. So beta types, it's usually mutation, not deletion. This is the difference, and it's on chromosome 11. So what's the patient presents like? Of course, anemia features, Clinical presentation is anemia symptoms like pallor, but there's also something, let's write down anemia symptoms. There are some things specific about thalassemia, with jaundice, splenohepatomegaly. That's why you do abdominal examination, bossing of skulls, like the skull is protruded, and maxillary overgrowth. This is very typical for thalassemia. You can look at the patient in the daycare. That's how they look like sometimes. Not all of them might look like that. Especially the carrier, they will look normal. Okay, how the types in Malaysia actually. B is way more common than alpha thalassemia in Malaysia, and more especially hemoglobin EB type thalassemia. In thalassemia, the types, there's the alpha thalassemia, beta thalassemia. It has another 3 subtypes, and the same with alpha. The other subtypes is for alpha is a carrier trait and hemoglobin H disease, and hemoglobin B Bart's disease. Actually, this is not compatible with life. There is hydrops fetal. We call it hydrops fetalis. The baby will die actually, but the carrier is just has asymptomatic. He's no symptoms. He's just a carrier that might give his thalassemia to a child. And the trait where there is a deletion, we have 4 alpha on each hemoglobin, right? So the carrier, when there is deletion of 1 alpha, so we have 3 to compensate, no problem. But when there is a trait, there is 2 deletion, okay? So we lost half of our alpha. So we will be having mild anemia, because still we have 2, they can compensate. If we have absence of 3 and 1, he cannot compensate easily at all. So we call it hemoglobin BH disease, where there is absence of 3, and it shows symptoms not like the 2-1 mild anemia. It shows extravascular hemolytic anemia, and he might require transfusion, okay? Might require regular transfusion. But if there's absence of 4, of course the patient cannot survive, actually incompatible with life. Let's talk of beta thalassemia. Beta thalassemia, it's mutation. That's why we cannot say that the beta is completely absent. It's mutated. It's not normal. We have minor, intermediate, and major. The minor one, we call it 0 to 1 or A thalassemia, which is asymptomatic also from its name. Intermediate one is severe anemia, but patients still require he doesn't require frequent blood transfusion. He might take blood transfusion, yes, occasionally, but he's still his life is okay. Major thalassemia, these are the people who require marked blood transfusion, and you can see more their special character of the thalassemia in them. Okay, so moving on. After the types, symptoms of anemia, we said light fatigue, dizzy, shortness of breath, irritation, palpitation. Very important in children We're talking about poor feeding and pallor. This is very important because usually the patient presents with pneumonia and then the patient is pale. Pneumonia does not cause patient is pale, so he has anemia. What type of anemia? Or further investigation found out that he has thalassemia. Palpitation, lethargy, headache, syncope. If it's severe, only syncope does not come usually with thalassemia, only if it's severe. Okay. What do you ask in your history? You have to ask how frequent he takes his transfusion, any hospitalization, any admission, even like for a short one, any reaction to his blood transfusion, to be any reaction like rash, fever, itching, dark urine, because we can see hemolysis for anything. How long he like his regular transfusion, how long it takes, is there anything hard for him during this duration, anything bothering him. For his iron chelation therapy, you must ask what does he take medication from the first place, doesn't he not, compliance or not, of course you have to ask. Okay, so now how do you diagnose thalassemia? Diagnosis of thalassemia, mainly we have, ignore this one is more clear. You start with full blood count. You will see an hemoglobin is low, MSV must be low, MSH must be low. So what we call this, we call it microcytic hypochromic anemia. Furthermore, when you do peripheral blood smear, you can see target cell. What are the target cell? They're circular cell, and it's like there's a point like this. The RBC will look like this, the target cell. Why? From its shape, like you're targeting this point, and you can see anisocytosis, which is different sizes of blood RBC. And you must do iron studies. Why? It's not like gonna be normal in thalassemia, because you have to rule iron deficiency anemia. Hemoglobin electrophoresis studies, now you suspect completely thalassemia. These are positive, as you've seen. You saw the target cell. You start doing hemoglobin electrophoresis to identify which types of these the patient has. And then you have to do some imaging to confirm furthermore. Sometimes they don't do actually, but we do skull x-ray. We look for something like this. Look at it, it's like hair, it's very hairy, right? Sometimes you just remember it's just hair and appearance, but why does it looks like? Because the skull is very important bone, has important bone marrow, and it's trying to compensate. So there's bone marrow expansion, it's expand more due to chronic hemolysis. Usually patient whose skull looks like this on x-ray, he's the one who's will be the patient of carrying these clinical features. Okay. And abdominal ultrasound for hepatosplenomegaly. Of course, you start with physical exam. If you suspect it, you can proceed with ultrasound. Counseling, also you have to counsel the patient for very important parts: family screening, routine blood, and admit for infection but pallor. Counseling, counseling, family screening, consuet, did he marry someone he knows, relative, future marriage, long-term treatments for future marriage for their children, especially if the father or the mother, both of them has thalassemia career, the risk they're gonna have, and things. Surgical, if he's well to have any surgeries, if there's any bone marrow donor for him. And then how do you manage the patient? For management, you have two main things: blood transfusion, if of course he's not just a carrier or he shows very severe symptoms, blood transfusion. And secondly is iron chelation therapy. Okay, iron chelation therapy, we have two main drugs, defroxamine and defrazirox. These are the main chelation therapy. And if he has very hepatosplenomegaly, even after treatment, you can do splenectomy. And the curative, there is a cure actually. If you think there's no cure, there is a cure, but it's hard: bone marrow transplant or gene therapy, which is very, very rare actually. You have so many money, you can do gene therapy somewhere in America or UK. Okay, now you manage the patient, you investigate your patient, okay. There are something you have to look for them regularly. Complication in thalassemia, okay. Always look for the patient's heart, his heart, because iron overload, like the patient has from blood transfusion, he will have iron overload. This is the effect of iron overload. What are the organs that get affected by the iron overload? Mainly the heart, the liver, the spleen, pancreas. Okay, we're gonna look what will happen in the heart. Cardiomyopathy. So cardiomyopathy, how do you monitor for doing ECG, echocardiogram? How, from only yearly you do it, not always. Your pancreas, it goes diabetic mellitus, so you do blood glucose every 6 months. Spleen, splenomegaly. Liver cirrhosis, you can do liver function test, ferritin, every 3 months. Pituitary, you can see that if there's any retardation, short suture, no sexual sexual impairment or late puberty. Also, you can do for pituitary growth hormone. You can access hypothyroidism, thyroid hormones, TSH, T3, T4, all endocrine problems. You can do them yearly. No need for like every 6 months. And skin, if you can tell the patient if you notice any hypopigmentation or bronze, like he exposed to the sun in a circular area, he can come for monitoring. And this is the most important part, actually, complication and monitoring. In most cases there are something like also infection, but nowadays it's not common because of the blood transfusion, because the patient is compliant to medication. So infection like hepatitis, malaria, dengue even, it's patient with thalassemia, their bone marrow is disturbed, so they are more exposed to these types of infection.